My talk will serve as somewhat of a bridge from Dr. Dean's talk, which of course touched on diagnostic issues, to the next talk, which will deal more fully with decongestive physiotherapy of lymphedema. But I'd like to give you a little bit of an overview of diagnosis and management of lymphedema. So we've heard very eloquently from Kathy Bates this morning that lymphedema suffers from this neglect problem, and yet it is relatively easy to establish a fairly concrete diagnosis in this context. We know that lymphedema can affect the leg, as we've just heard, the foot, the hand, the head, the neck, pretty much any part of the body that has lymphatic flow. If that lymphatic flow is interrupted in some way, can experience the edema of the disease that we're talking about. And the issue is that the lymphatic system, like any organ in the body, has a failure state. We all recognize this as clinicians, these various entities that we consider to be the end product of the failure of an organ system. When the lymphatic system fails regionally or even more profoundly, we will see lymphedema, whether it is within an exterior part of the body, a limb, or in the viscera. We have to acknowledge that this is a chronic disease. It's debilitating, again, as you heard from Kathy this morning. It's frequently misdiagnosed, it's treated too late, or often it's not treated at all. Now, these days, of course, patients are relying increasingly on the internet to wend their way to the appropriate physician or the appropriate form of therapy. And I don't think we can quite rely on the iPhone yet for lymphedema, but it's almost that simple, which is that we really need a good physical examination. So this is an example of pitting edema. We're all familiar with this. I want to clear up one misconception that crops up often in that 15 to 30 minutes in the 4 years of medical school. It's often said, if it pits, it's not lymphedema, and if it's non-pitting, it's lymphedema. And neither one of those statements are strictly correct. Lymphedema always passes through a stage of pitting, as you see here. This is a patient with lymphedema, but I do want to point out that if this were one of my heart failure patients, for example, I never would have had time to create the pit and then pick up my phone and take the picture. So the ability to create a long-lasting depression like this is based on the glycoprotein content of the interstitial fluid, which traps the water molecules, and when they're physically displaced, they're held up by mechanical forces for a period of time before they migrate back. It's a little bit like a child playing with melting jello with a spoon. You can sort of move the water around within a collagen matrix, and that's basically lymphedema. There is a sign that is considered to be relatively pathognomonic when it's present, but it need not be present, and that's the so-called Stemmer sign, which is the inability to tent the skin at the base of the digits in lymphedema, which is really a manifestation of the increasing fibrotic changes in the skin. But again, it need not be present. This slide simply illustrates what Dr. Dean was talking about in the context of phlebolymphedema, which is that you can get the classic findings of lymphedema either if the lymphatic circulation is obstructed, as it becomes in the treatment of cancer or perhaps in filariasis, but also in venous disease, as we've heard, simply because with the increase in venous pressure, there is an increase on the afterload of the blood capillary, which results in greater filtration and in turn a greater lymphatic load or lymphatic preload. And when the lymphatic system becomes exhausted, we have lymphedema. I think we've heard about this already this morning. If not, I'll just review it briefly, which is the staging classification of the International Society of Lymphology, which clearly indicates that we progress from a stage of disease where there is no detectable edema. We can consider that the preclinical or stage 0. Then we go through a distinct stage of pitting in which there is complete reversibility, and gradually with time, with the structural alterations that occur, the reversibility is lost. Part of the problem in the diagnosis of lymphedema is that there is often, particularly in the cancer-related world, but also certainly in the phlebolymphedema world, a long period of latency where the lymphatics are able to compensate. And it may take, for example, in the case of cancer, as much as 3 years or longer for a surgical insult at time 0 to make itself manifest in the patients who eventually develop the problem. To look for the stage 0 disease, we're increasingly relying on this technique of bioimpedance spectroscopy, which is a simple bedside technique that is now commercially available and has a reimbursement code in which we can detect the presence of increased interstitial fluid before it is detectable by any physical means. This is what the device looks like, and it is attached to the patient by simple skin electrodes. It takes about 5 minutes to do, and it is an extraordinarily sensitive test for the presence of regional edema that can allow us to detect lymphedema at its earliest stages of appearance and thereby allow for very early and often curative interventions. Eventually, specifically if bioimpedance spectroscopy is not employed or is unsuccessful, we will progress to this so-called non-pitting phase, which represents stage 2 and stage 3 of the ISL classification. Here, no amount of pressure by the examining finger will do anything more than create a little bit of superficial skin erythema. And this, here you can see a similar finding in a child with primary lymphedema. This is because with the passage of time, there are profound structural alterations in the tissues as a reflection of the response to the lymphatic fluid being present in the interstitium. So we see tremendous thickening of the skin to many times its normal dimensions. On an MRI like this of a human thigh, we shouldn't be able to see the skin at all, and here it's as thick as the cut edge of a grapefruit. More importantly, in fact, is the phenomenon that in the layer of insulating fat that we all have under the skin, in response to lymphatic edema, there is eventually a tremendous overgrowth to many dozens of times its normal size. Body fat at room temperature is liquid in behavior, so it superficially is an edema. But it will not pit, of course, because it is encapsulated into millions of individual adipocytes or cellular boundaries. And eventually we get tremendous changes of inflammation and the superficial evidence of the profound alterations in the skin that accompany what I showed you is occurring more in the interior. So beyond the physical examination, which again should suffice in well over 90% of cases, a well-trained physician, and that's, we hope, the purpose of the session this morning, should be able to make this diagnosis at the bedside. But there are specific imaging techniques. We've largely abandoned direct contrast lymphography because it is very difficult to do, very time-consuming. Gives us information that we don't really need in most cases, and the lipid-containing contrast may actually be toxic to the lymphatic endothelium. This would be considered, I think, the gold standard for imaging today still, radionuclide lymphoscintigraphy, injection of a labeled macromolecule into the distal aspect of either the hand or the foot, in this case the hand, looking for disparities in the arrival time in the draining lymph nodes. So this is the lymphedematous limb that not only has very delayed uptake of the contrast in the axillary nodes, but also very profound dermal backflow. This is what it looks like in lymphedema distichiasis that Dr. Dean mentioned, which is characterized by a profound degree of reflux, both in the veins and in the lymphatics. So you see this very intense dermal backflow that looks like the patient is wearing a pair of boots. And we can see in lymphoscintigraphy even changes over time so that we can use it in a way to gauge the natural history of the disease as well as to establish the diagnosis. Indirect MR lymphography is not done commonly in the United States yet, but it's commonly employed in Europe and Asia. And this involves injection of gadolinium contrast directly into the skin to create the uptake in the lymphatics, which gives us much more resolution of the vessels themselves rather than just a functional evaluation. And in fact, with MR lymphography, we can actually see the large central lymphatics like the cisterna chyli below the diaphragm and the thoracic duct up above. This is the new child on the block and one that is gaining a lot of attention, specifically in the world of surgery related to lymphedema. Again, Dr. Dean mentioned it. This is indocyanine green or near-infrared fluorescent lymphography. Again, injection subcutaneously, in this case of an agent, which then gets bound to albumin, which makes it have obligatory uptake by the lymphatics. and we can see the difference between a normal, very linear uptake of the material in the lymphatic channels versus the pooling that we see in this case in Milroy's disease because of an inadequate lymphatic anatomy. And we now understand that there is a progression in the anatomic defect that occurs with the worsening of the disease. These various approaches have differing sensitivities, and as Dr. Dean mentioned, lymphoscintigraphy is highly specific to lymphedema, but it is not extraordinarily sensitive. Once we make the diagnosis, and this you'll hear about much more in the talk to follow, we try to employ our physical therapy techniques as early as we can to try to limit the amount of edema accumulation and to limit the progression of the more structural aspects of the disease. This is a hypothetical schema. It's actually never been shown, but we believe it to be true to at least to a degree, that earlier intervention actually will at least retard those biological responses to lymphatic edema that lead to the latter stages. You're going to hear about this in just a moment, so I'm not going to dwell on it. Of course, the hallmark of the maintenance therapy of lymphedema is the use of the compression garment, which is not meant to reduce the size of the limb, but to ensure that it does not reaccumulate edema fluid once treatment has been successfully employed. We have a variety of alternatives to the simple compression sleeve or stocking when those cannot be employed by individual patients. We also have intermittent pneumatic compression devices that are not standalone therapies but can be used adjunctively to everything else that I've mentioned. At the end of the day, decongestive lymphatic therapy is quite successful at reducing edema volume, and on average, in many, many studies that have been published now, on average we can reduce the excess edema volume by about 50%, and that is true not only of an impact on edema, but also on the little recognized fact, which differs from what typically is said in the textbook, that lymphedema is not a painful condition. In fact, almost 100% of the patients that I see in our clinic complain of some element of pain, and again, decongestive physiotherapy can reduce that pain component by about 50%. So what happens if treatment is delayed or withheld? Again, this is ultimately a structurally and functionally profound disorder, and all of the things listed on the left-hand side are phenomena that we see in untreated or undertreated disease, and I believe that all of them in aggregate are responsible for the long list of problems that lymphedema patients encounter. So it really behooves us to make early diagnosis and rapid intervention. We don't have any cures yet. I hope they're on the horizon, but effective therapy does exist, and as clinicians, if we can make the diagnosis, we can deliver the treatment. So thank you very much for your attention.